Hello, this is Dr. Ford Brewer with PrevMed, Heart Attack and Stroke Disability Prevention. This is the third and hopefully the last in a series on heart failure. The reason I say that is, like most adult Americans, heart failure has touched me. It was the cause of my father's death. Like many heart failure patients, he had had a heart attack just a few weeks before that. That heart attack blew out a lot of his heart and muscle ability to function. And I've had memories whenever I go into my own high-intensity interval training, and I'm breathing hard. I often still remember my dad breathing hard, but he wasn't doing a high-intensity interval. He was lying flat in the bed. In addition to breathing hard, he had the froth coming up from his lungs. It was fluid that's backed up by the heart pump failure. So again, it's a painful discussion for many of us, but it needs to be done. You can't talk about heart attack, stroke, and disability prevention without talking about heart failure. You also shouldn't talk about heart attack, stroke, or heart failure without talking about dementia and loss of cognition. By the way, one other comment about my dad: he had dementia as well by that point. Now, what kind of problems do you get with dementia and loss of function? As we mentioned previously in part 2, half of patients that have been hospitalized for heart failure have problems with mentation, with their brain working. And there are multiple reasons why, but it's been characterized. Let's go through that real quick. As you see, cognitive domains that are affected. Your visual spatial is affected. And remember, when you send these patients home, they've got an oxygen tube hooked to their nose. They often will have problems walking and moving. They've got to take 10 to 20 pills multiple times per day. And many of those pills cause them to lose fluid. In other words, have to go to the bathroom. So again, I'm just helping us understand the patient experience of end-stage heart failure. And how, again, talk about some of the things that are being done to prevent some of these problems. Prevent them later on, more of a tertiary prevention after you've gotten to this level. We've spent all of our other videos, and there are about 100 of them now, talk about primary prevention or secondary prevention, how to keep you as a patient or your family member from getting to this end-stage area. It's an end-of-life area. So you have visual spatial loss, you have attention or concentration loss of ability to think. Your processing speed goes down. Your executive functions, you can't make a decision. You can't learn. So you're going to send a patient like this out with, again, 10 to 20 meds, tell them to take those and an oxygen tube and say good luck. No wonder so many of these patients end up back in the hospital within 30 days. Now, here's maybe a better way to look at cognition for heart failure patients. This is part of the mini cognition test that's done by the Cleveland Clinic. One of the things they do for patients that are being discharged with congestive heart failure, they ask them to draw a clock, and they give them the time that they want them to draw on it. Well, as you can see, this patient did pretty well. This one didn't do that badly. This one, maybe not so good. Now, think about this patient, and this patient, and this patient even this patient who put down the wrong time. Think about these three patients and their ability to learn the schedule for taking 10 medications and, again, managing the oxygen tubing and all of the other things that they have to manage when they're being discharged for congestive heart failure. There are other issues regarding, when you look up readmission rates, you see a whole bunch of information about costs. And yes, like the original CDC site said, it's about $31 billion in costs that we're spending on heart failure these days. But there's, again, a very, very personal patient-related issue associated with readmission. Readmission is not fun. I know this is misspelled, by the way. But this is something I got off the internet where it's talking about hospital psychosis. For those of you who think that it might not be that bad for patients to go back into the hospital psychosis is seen quite often with patients with congestive failure. And it's not, again, it's not a great thing either. We call it sundowning. It's one of the major challenges for interns. It's associated and risks come from things like already having some dementia. There's also some other things in terms of the hospital experience itself that continue to cause this problem. You get a change in your internal clock. You're exhausted. Again, remind you of the picture of my dad with the huffing and puffing. It's like running a marathon, except it never stops, and you can't stop and walk. You're exhausted. You can't think. You do lose your 24-hour or diurnal pattern of brain thought. You have anxiety for obvious reasons, depression, and then you've got medication and the side effects associated with medication. So now, again, I've drawn a very ugly picture, and it's a very ugly disease. Hopefully it will, like many of the things I do, help us as individuals do the things we need to do to prevent from getting there. But here's some information on what do we do once the patient's already gotten there and how can we help. Unfortunately, there's not a lot, but there are some things. This is put out by the Institute for Health Care Improvement, the IHI. IHI was started mostly by a fellow named Don Berwick. He was a major proponent of hospital quality and healthcare quality. He did made one of the better contributions to healthcare quality and was very much respected for a long time. One of his major contributions was to get away from attribution of blame for a healthcare provider. Blame doesn't really help in terms of finding root causes of quality problems. But what did back to heart failure, and what did the IHI say in their 5 million lives saved program? First of all, assess left ventricular function. Well, you're going to see these, by the way, in a bunch of other places. The second one was ACE inhibitors. You remember how many times have I said in other videos that ACE inhibitors are better and they're preferable to ARBs in terms of management of blood pressure and especially in terms of some of the other things associated with this, like diabetes. If the patient has atrial fib, you need to make sure they have an anticoagulant. If you look at my practice, one of the things that I'm often doing is working with a patient that has atrial fib, not to the heart failure stage yet, but they have atrial fib and they're not on proper anticoagulants. For these patients, pneumococcus and flu vaccines, those are critical, simple reminders that we tend to not think about when a patient is in this end-of-life type of scenario. But flu vaccines and pneumococcal diseases are preventable and are often the straw event for these patients. So these items are all old items that have been around for a while. What about some of the new items, like having the patient stand on a scale every day and using that scale rigging that scale up so it has remote impact back to a nurse or a care manager? Well, we'll talk about that in a minute. There's several things that are going on right now. I had lunch with a fellow named Brooke Bishop. Brooke was very helpful in terms of helping me understand some of these issues and areas. He founded a company called Spiras, S-P-I-R-A-S. That he carried that company, by the way, through this is Nashville. I live here in Nashville. It's often called the Silicon Valley of healthcare, where all these new startups are going. And Brooke, yes, started this in our incubator, a Nashville healthcare incubator called the Foundry. But what about Spiras? What do they do? Actually, if you go to the website and you look at it, they're really all about COPD, chronic obstructive pulmonary disease, or serious lung disease. What's the connection there? The bottom line is, folks who research congestive heart failure have made the statement more than once. At this point, once you have somebody that had to be hospitalized for congestive failure, it's not about the heart so much anymore. It's about the patient. The patient can't breathe. And again, with all of this picture, pardon me if it's bothered you, that I've painted of the challenges of the patient experience for congestive failure, I left out the worst one. You can't breathe. It's a struggle to breathe. So groups like Spiras, and I don't think there are many of them, they're basically sending respiratory therapists out to the home to deal with the patient and help the patient look at practical reasons for breathing better, or practical ways, practical countermeasures for breathing better. Just as we continue to round up some of this care for congestive failure patients, I'll just cover a couple of academic articles and then put this to rest. This is the most cited article. It is regarding how to manage and prevent rehospitalization for patients that have been hospitalized for congestive failure. It was done in 2015. There has obviously been more research that's happened since then, but nobody has broken the code on how to prevent congestive heart failure readmission. There are good programs that are growing. Many of them have come out since this article, but again, it's not an easy issue. This article found that there's really no one technique. There are many techniques where there are many programs where use of multiple techniques did help. And I have to make a rant here. They said they couldn't really tell anything about use of remote items. I've had my share of remote activities. I do telemedicine for my heart attack and stroke patients. I used to help, I was the chief medical officer for MDLIVE, one of the large telemedicine companies in the country. I see so much miscommunication and misunderstanding of these new remote techniques. People don't understand that, look, ever since telephones were invented, doctors have been talking to their patients on telephones. So, and you would call that telemedicine. So telemedicine is nothing new. There's just a major explosion of remote or telemedicine techniques associated with video and the other technologies that are available. Now, I'm not going to go through the details on this, but I do think it's helpful to just start looking. This is the list of the studies that were reviewed in this meta-analysis. And at the end of the day, they said, like I said a minute ago, there's no one study that's broken the code yet. And I would venture the guess, or I would venture my own statement that the code has still not been broken. Now, let me go and look at another and show you another list that was covered in here. I think that might be a little bit more helpful. And this is a list of what were the actual techniques that they looked at. So, discharge planning. For a long time we thought that it was just a problem with discharge planning. that is part of the problem. Our failure of case management or lack of case management, yes, that is part of the problem, and improving those have helped. But not just one of those. You have to have multiple components here. Telemonitoring, yes, we just mentioned that a few minutes ago. Telephone follow-up, again, these remote issues or remote techniques, those helped. Self-management. Well, again, self-management helps, but here's one of the problems with the research. You've got some patients who can draw an accurate clock. Half of the patients who can't. So self-management only works for the patients that have the mental capacity to do that. Home visits, again, multiple different components here, and we won't belabor the point. Bottom line is, congestive failure is an ugly disease. It's an ugly problem. It causes major challenges with quality of life for our patients and major use of healthcare resources. Most, if not all of us, will be touched in some way, either by having it ourselves, 1 in 5, helping or experiencing a family member having it, or helping to pay for it. So, as I've said multiple times in the intro to my videos, it's difficult to prevent disease. For example, preventing heart attack and stroke. To prevent my own, I've had to go spend 30 years on a plant-based diet. Then I still got insulin resistance, so I had to go to plant-based but remove all the carbs. We'll talk about that in an upcoming video on what the health. I have to take medications. I have to take ACE inhibitors. I'm taking metformin now because, again, I'm at the age where I'm having some insulin resistance. And of course, if you have plaque, like I've had, I've reversed it. My plaque is now down, or my arterial age is now down to about age 50. But it started out just a few years ago at an arterial age of 72. When you have that kind of plaque, you need to be taking a statin as well, but we need to make sure it's the right one. So, again, it's always something.